This conference will now be recorded.
In the prior 4 needs assessments. However, one of the things that we intentionally did was change the way we talked about these priority areas. So you can see our first priority, chronic disease and life expectancy. And so when we talk about chronic disease, we're going to talk not just about disease prevention, not just about risk factors, not just about improving people's health and well-being related to chronic disease or disease management, but we're going to talk about the difference in life expectancy between segments of our population, in some cases segments of our population that live only a few streets apart from one another, and bring that back through to look at it through a lens of social determinants of health and health equity. Our guiding goal there is to achieve equitable life expectancy for all people. And that is a lofty goal, and as we go through here, we'll break down both some of the data that we have determined that support both this priority area and goal, as well as some of the specific objectives that we'll be measuring towards this goal. Maternal and child health is another area that we have consistently worked on across the nation and certainly here in New Jersey. We'll talk more about both the data that supports this goal as well as some of the efforts that are happening within the community. One of the things that we really wanted to, again, recognize here was not just improving access to care issues like prenatal care or postnatal care, but achieving equitable outcomes for all mothers and babies, particularly Black mothers and babies, where we're seeing such disparity in birth outcomes. When we talk about behavioral health, we've introduced the idea of also addressing trauma, and with our goal being to reduce and prevent the impact of ACEs, or adverse childhood experiences and trauma, on health outcomes, recognizing that trauma and ACEs are grown out of structural inequalities, structural racism that exists and perpetuates within communities of color particularly. And then of course COVID-19, and using COVID-19 and the lessons learned through COVID-19 to better articulate the disparities that we see among populations in both being able to take safety precautions as well as experience higher risk of disease and death from disease. Our goal around COVID-19 is to reduce death disparities among population groups. We'll talk more about each of these areas. Okay, I'm not going to read through every item on our key findings here. The report is available, which we have here alluded to each of the page numbers where each of the key findings are. But you can see on the left side here is our priority area, which is chronic disease life expectancy, specifically focusing on life expectancy, our guiding goal, and then kind of an orientation as to why this is our priority area. But some of the factors that have played into this as a priority area are looking specifically at life expectancy across Mercer County and life expectancy within specific populations. And so that first point, I think, is really a strong one, that across Mercer County, life expectancy is on par with New Jersey. But when we start looking at particular populations, specifically populations of color, we start to see that life expectancy getting lower among race and ethnic groups, while it maintains the same level among white populations. This helps us to demonstrate that there is not only a disparity here, but underlying inequities. And this is a theme that will repeat itself throughout our research as we look at how some people within Mercer County, particularly those white people, people of more affluence, people in certain geographies, are experiencing all the excellent health care and opportunities that Mercer County presents, while others in our community are experiencing higher disease rates, higher death rates, poorer socioeconomic levels. And we've used these data to help us demonstrate inequalities or inequities within the community. So just a couple of data points to spell this out a little bit more clearly for you. So as we look specifically again at African-American, Black African-American people across Mercer County, more likely to die from all of the top chronic diseases, as well as infant mortality. So we're looking here both at adults as well as children. And you can see in both cases, the first bar there are among Black African Americans, and the death rates are at least double that which we see among the white populations for children under 18, and a little less than double among the older adult population. Same story when we look at heart disease rates. Here we're also seeing higher rates among Black and Asian people across Mercer County. Again, we're using the health data as a way to measure both disparity within the community, but also underlying inequities, and demonstrate that some people within our community are faring well when they contract disease, or they're being able to prevent disease, or prevent disease earlier than when we look at disease among other populations within the group. Diabetes is another example of that. And so when we designed the community health improvement plan, we took an approach that the GMPHP would be the guiding force, or the North Star, we said, for the CHIP, and that they would have an eye towards the goals that we have outlined, as well as measurable objectives towards those goals. And these objectives are intentionally lofty. These are not things that we expect we're going to be able to attain in a short time period. There are some waypoints along the way that hopefully we have short and midterm as well as long-term goals. But the measurable objectives here are meant to be where GMPHP and the collective group really looks at how are we having a collective impact in our work together and individually within the community. From there, we designed and recommended some institutional strategies, particularly that reflected health equity, that individual institutions could adopt that would align with those measurable objectives, but could also be measured by the institution. It's really important as our hospitals, our public health departments, our health and social service partners, and others in the community, as you are doing the work to support your missions and the individuals that you serve, that you're able to measure your work, your programs, your resources, and the like. But we also wanted to make sure that we weren't just bean counting. We weren't just counting the number of programs, the number of people, the number of pamphlets, the number of activities, but we were looking at process improvements. We were looking at policies. So going back to what I was saying earlier about those institutional policies that can perpetuate racism without being intentional. So we incorporated that into some strategies here, and we called them health equity strategies as we discussed them with the GMPHP CHNA group. So we'll go through each of these areas, each of the priority areas in a similar fashion, but I wanted to take some extra time with this first one to kind of orient the group to our process, how we use the data to help define health inequities, and also developed the community health improvement plan towards addressing those inequities.
Thanks, Colleen. The next key focus area is maternal and child health, specifically looking at achieving equitable birth outcomes for Black mothers and babies, infant mortality. So the question arises, why are we even looking at infant mortality? Not everybody provides prenatal care or delivers babies or anything like that. The reason we're looking at infant mortality is twofold. One is internationally, infant mortality is used as a key measure of the health of an overall community because it is so sensitive to the impact of general structural factors, things like the education of the mother, public safety, secure housing, access to food and healthcare, things like that of a structural nature. And the reason why the CDC, the WHO, and others look at infant mortality as a key measure of community health is because babies shouldn't die. And a major contributing factor to the reason why that happens is all of those social factors. And those social factors are developed in large part because of long-standing inequities. For example, in the past, in my lifetime, there were restrictive covenants, for example, in housing that prevented certain kinds of people from buying a house in particular neighborhoods. And those restrictive covenants largely focused on external features such as race, ethnicity, religion, things along those lines. And because of those rules, people who were not white were unable to access mortgages to buy homes in those areas. They were locked out. This is a thing that happened in my lifetime. And as a result, those communities developed over time being white, and other communities developed over time not. And those communities where people had greater access to buying their own homes, the families that were able to live there were able to increase the asset of their home. Other people who were locked out of the opportunity to buy a home never had access to that asset. Fortunately, we live in a day and age where we are taking steps to address those sorts of inequities that have existed historically, but the end results of those policies and procedures that were in place still have an impact today, because there were families who were able to save money and to create an investment by purchasing a home, and other families that didn't have that opportunity. And as a result, the neighborhoods that had greater home ownership had more investment in terms of property taxes, which provided greater opportunities in the school districts in those areas. And there were benefits upon benefits that were achieved in some areas versus others. And that is when we are talking about structural racism, we're talking about the long-term impacts of those inequities that existed. We didn't create those, but we live in a world that comes from that. So here we are today, and the point is to be intentional about looking at those factors and how they play out, because we all know that education, housing, public safety, and income and assets directly impact our ability to make healthy choices and live healthy lives over the long term. So infant mortality often is a representative of areas where these kinds of inequities have existed and continue to play out in terms of negative outcomes in this way. So when we look here at Mercer County, it's not great. In fact, it's not great for everyone. It is great for most people. We have very excellent healthcare, particularly around obstetrics and delivery and prenatal care. We have fantastic birth outcomes as a general statement if we look at the community as a whole. But if we take apart and look by race in our county, it doesn't work the same for everybody. If you look at infant mortality in Mercer County, we have some of the highest rates of infant mortality of anywhere in New Jersey. And the rate of infant mortality for African Americans in our county is 13.1, compared to the overall rate that is 5. That's more than 2 times higher than what it's like for everybody else, not only in our county, but the rest of the state. And that is an inequity, and it is inexcusable. And when we look also at the life expectancy goal as well, when you see decreased life expectancy for African Americans within our county, this is a contributing factor to that, because the amount of years of life lost if you die before your first birthday is enormous. And it has long-term outcomes for the health and well-being of our community as a whole. And this is important to look at because the major interventions for this have to do with structural issues, things like housing security, public safety, education, employment. Those sorts of factors are the driving factors towards contributing towards these things, which is part of why the CDC, the WHO, and others use this as an important measure of community health. So whether or not we provide prenatal care through our own institutions is not the major factor here. We have fantastic resources. We have fantastic services that are available to moms and babies within our community. It's our responsibility to make sure that all of those fantastic resources that we have available are reaching everyone. And what's been exciting in the past year is seeing collaboration amongst the GMPHP members towards this goal already, which is fantastic. So there are already initiatives underway right now that will be rolling out in the next year, addressing these things head on directly through the collaboration here. So this is a problem, and there are steps being taken to address it in a collaborative manner. This aligns also with the Nurture New Jersey 2021 plan, which is the statewide plan looking at maternal and child health for the whole state. And what the one of the number one goals out of the plan is to build racial equity infrastructure and capacity, because these inequities are seen throughout our state, and they are a feature of this long-term inherited situation that we have that has created different opportunities for people. So we didn't make the structural racism ourselves, but we live in a world where it's manifested now. So here we have a number of measurable objectives and institutional strategies that work towards addressing this goal. So yes, we want to save moms and babies. We want to improve these numbers. There's lots that we can do. And we have fantastic resources in maternal and child health in our community. So there's an opportunity for anyone, whether or not this is your priority area of your institution or not, there's many opportunities for people to get involved in this particular initiative and to have an impact on the lives of people within our community. The next area, which is also related, is in behavioral health and trauma. So behavioral health has consistently been a key area of emphasis, not only here in Mercer County, but throughout the country as well too. We do have issues around mental health and substance use disorder that are chronic, and we've made a lot of great strides here in Mercer County in addressing these issues as far as providing access to clinical resources and other things like that too. What this goal is taking a little differently is building upon the initiatives that started in the previous community health needs assessment that took place the last time, that started to raise the issues of adverse childhood experiences. Now, adverse childhood experiences are factors that people experience that are negative before their 18th birthday and have long-term outcomes. Now, some of the examples of what an adverse childhood experience could be are things like divorce, the loss of a parent, homelessness, a variety of other things. Now, many children experience one or many of those and in their lifetimes, and those are things that are going to happen. However, those situations are exacerbated by adverse community environments. So if you have parents who are getting divorced, which is a thing that can happen to anyone at any stage, and you combine that with a variety of other community environments, the impact is exacerbated. And if we can work towards building resilience and addressing the adverse community environments to make them supportive community environments, we can address and ameliorate the impact of some of those tragic things that inevitably may happen in the lives of any child in our community. So that's one piece of it. The other is to educate ourselves that when we are seeing adult patients, to acknowledge the experiences that have brought them to the stage that they are at when they are experiencing negative health outcomes, and to be sensitive to some of the underlying issues that have brought about the manifestation of things such as chronic diseases. So if we look at unexamined, untreated, unrecognized adverse childhood experiences, they result in a variety of different negative outcomes as adults for those children if we are not addressing them at some point before they get to that point. So what that means is if we are addressing adverse childhood experiences on the front end, and we are sensitive to those things when we are dealing with our adults as well, then we can look at these levels of reductions in terms of health risk behaviors such as substance use disorder, depression, things like that, smoking, as far as health outcomes such as depression, anxiety, even things like coronary heart disease, and then also socioeconomic challenges, because shouldering those adverse childhood experiences alone makes it more challenging to complete the levels of education that you might have otherwise been able to, or achieve the jobs that you need, things of that nature. So what we're looking at is not only addressing the behavioral health issues that we're looking at in general in their manifestations right now, but looking at them in terms of their root causes and working towards building resilient communities and recognizing the impact of these things if they continue unexamined throughout life. And this is evidenced also in our key informant survey. So one of the issues that we asked about when we surveyed more than 200 different representatives of community agencies and leaders in our communities was, thinking of Mercer County as a whole, how do you see these key components of the social determinants of health? Things like education, economic opportunity, social and community context. And if you look here at this graph, most of it is yellow, which is average. And so when we asked, why did you call it average here? Overwhelmingly, the results that we got was, I didn't know how to answer that question, because in Mercer County, we have extreme poverty and multimillionaires living within a few miles of one another. So I don't know how to answer that question responsibly if I'm looking at the entirety of Mercer County. What that says is that we have fantastic things here in Mercer County, and we know how to create green space, to create walkable streets, to create paths and trees and good schools and economic opportunity. We just don't have it everywhere. So, you know, we have a lot of opportunity, we have a lot of capacity here, we have a lot of resilience. So this is an opportunity to take those negative experiences and use the positive that we have to reinforce our community in a broader way. So we can see that here too. This is just a basic table that's looking at poverty indicators in our towns and our county and our state and the United States in general. And we can see that dark blue area is areas that exceed the average. So they are better than average in Mercer County, in New Jersey, and across America. So we have a lot here in Mercer County. But the orange you'll see too is far below all of those things too. So we have some of the highest and the lowest here within our county. So the tools that we need to make life better for all of us are here. But we live in a very diverse area. So we also too have had a history of need as far as behavioral health goes as well. All of these data that we have that are documented at this point also are from before COVID. So we don't have, just because we're still in the midst of COVID right now, we don't have solid data about the impacts of these things today. However, I feel very strongly that I don't think behavioral health and mental health issues improved during COVID. So, you know, we see that we did have issues here amongst our population before, and with the number of deaths that we've experienced, people who've had long COVID, the isolation that we've had during this time period, the opportunity for negative behavioral health experiences, I think have increased, not decreased during this time. So as far as our strategies, we're looking at things like creating opportunities to work towards equity, to build a community where food insecurity, hunger, housing stability, things like that are more equitably distributed, to make investments in those sorts of ways, and then also to educate ourselves about the impacts of those sorts of things on the people that we are serving in our organizations. So to be mindful of the experiences that might have brought them to this point that maybe are more primary in their mind than the manifestation that you're dealing with at that moment. So some of it is a matter of educating ourselves about these factors as well.
Okay, so let's talk about COVID and its impact on both the needs assessment, because we've conducted a very different needs assessment because of COVID, and the impact on all of your organizations as you've responded to COVID, and most importantly, the impact of COVID on our community. And as you've heard throughout, we have been able to use many health and social indicators to demonstrate disparity and underlying inequities. And COVID has become a very reliable case study in this exact fact. And so some of our key findings here will reflect back to what you've already heard about chronic disease, maternal and child health factors, behavioral health and trauma, and COVID has really just helped us to demonstrate that through the experiences here. So one of the things we did early on when we recognized that we were not going to be able to have the same level of community engagement that we typically would have in a needs assessment, we saw an opportunity to work with how we were already interacting with populations within the community, and large populations at that, through the vaccination clinics. So working with the GMPHP group, we developed a survey that was available at each of the COVID sites, and people could access it on their smartphones. It was available in English and Spanish, and we had translators that could help if people needed in other languages. And you can see that we had over 1,000 responses to this survey that helped us to understand what people were experiencing as far as COVID, where they were going for sources of information, how easy it was for them to receive vaccination or to get tested, and other factors that would help us not only improve the rollout of vaccinations, because we did this last spring as the broad rollout was happening, but also lessons that we could apply for future health emergencies. So one of the big things, big takeaways that we had from this was recognizing how much people rely on particularly their local health department in addition to their doctor and health provider. We know those top two, TV, radio, media, friends, family, typically tend to be the biggest drivers for people to collect information or get information. They put a lot of stock in that. But to be able to see our health departments come up as the number 3 and the health providers as the number 4 in this list is really impressive. That's not the case in every community. It's not the case in every state. And so we see this as a huge opportunity to leverage through continued information that is accurate, that is relevant, that is timely, to continue to help people to stay safe, to know what they can do, and to take advantage of the expertise within the healthcare system. The other thing that we asked, among others, was what made you want to get the COVID vaccination today? And we see, number one, people's individual health. They were concerned, and we saw that certainly among our high-risk older populations and the like. But number two, for the health of my family. Where we know there is still a lot of work to be done is among some of our most vulnerable populations, communities of color, and we continue to look at those ways that we can increase vaccination rates, increase the relationships and the trust between communities and healthcare providers. And that's the work that are continuing today and are able to use the results from the survey to help look at what are the right communication channels, who are partners in the community that we can work with to provide vaccination sites that are close, that are convenient, that people feel comfortable going to. I said COVID was a study in how health disparities and underlying inequities play out. And we can see this very clearly in this table. When we look at the leading causes of death across New Jersey residents, all New Jersey residents, when we look across white non-Hispanic groups, we see COVID as the third leading cause of death. And this is in 2020. And that's bad, right? So it has creeped into the top causes of death. But when we look across our communities of color, specifically Black, Hispanic, and Asian communities, it is the #1 cause of death. And when we also look at the count of deaths within the population, we recognize that there is more death among a smaller percentage of the population. And so it really helps us to understand how the impact of the socioeconomics, social determinants of health, health inequities have culminated into a perfect case study of how health disparities affect mortality. So we asked our key informants about the experiences of the people that they serve and work with in the community. And we wanted to understand how easily people were able to access COVID services, testing, use PPP, and what made it more likely for them to be able to do that. So understanding the activities that made it more likely for people to be able to access COVID testing, as well as the availability of it. Also, community support was seen as one of the top pieces, and that brings us back to understanding the role that our partners can play, both within GMPHP as well as new and different partners that we haven't worked with yet. And who are those neighborhood champions and those go-to people that we can leverage in order to increase population among more vulnerable populations. We also asked what made it made it unlikely for them to be able to do the activities. So lack of care, lack of access to care, #1, and that's not just the availability of care, but it's the ability to get to care, which really helps us to understand the socioeconomic factors, which come right underneath as #2, and thinking about things like transportation and where we have vaccination clinics, and do we do mobile clinics, and can we work again with unlikely partners to reach populations. So when we looked at developing measurable objectives for COVID, we wanted to be very specific to COVID itself and look at vaccination rates, look at leveraging our healthcare providers, our public health departments as a trusted resource among all populations, so deepening those relationships with more vulnerable populations and communities of color, and also providing that targeted outreach within communities of color. When it came to creating institutional strategies and looking at what each organization can do, the partnership, being able to host local vaccination sites, being able to provide information, to host awareness, to help people get access to online tools and know how to use their smartphones to access information and also be able to communicate with their healthcare providers. Okay, so I'm going to hand it over to Carol to talk more about the GMP collaborative, and then we'll come back and wrap up here at the end. But I think we'll let you go.
Hello, everybody. I'm Carol Nicholas with the Greater Mercer Public Health Partnership. I'm the project director, and I've had the pleasure of working with you for the last 3 community health improvement plans, and I'm looking forward to continuing that with this particular plan. Pre-COVID, we had 4 work groups that met in person quarterly to share the progress and partner. Twice a year, we would meet as a large group to share the updates and host a topic of interest or professional development. COVID forced all of us to re-examine our strategies and how to continue advancing our missions in a safe, sustainable way. During the key stakeholder discussions, the words trust, empowerment, communication, inclusion, collaboration, and community were used to describe the benefits of partnering with the GMPHP. As partner organizations shared their goals and barriers, we were able to help them partner with like-minded organizations to overcome the barriers. For example, we helped providers of diabetic education find partners who had a viable location but no teacher. We connected the Chronic Disease Coalition with a cancer center to run a thriving and surviving program. 3 years ago, we showed the movie Resilience, the biology of stress and the science of hope, which explains the science behind adverse childhood experiences and the long-lasting health consequences. Because of this professional development, we now have ACEs included in the curriculum at TCNJ nursing program, an ACEs work group in Trenton working on making Trenton a healthy city, a healing city, and increase awareness of the importance of trauma-informed care training. In 2018, the coalition wrote a letter to the legislature requesting improvements in healthy food choices in Trenton and action to improve the food desert. Trenton Health Team followed up with their request for information in the spring of 2021. Working together, we can help create environmental and policy changes that will impact the health of Mercer County residents. The data that you've just heard is essential for any grants you hope to write in the future. We were so pleased when Professor Seals of TCNJ offered to write a health literacy grant and collaborated with the Trenton Free Public Library. The library now has many topic bags filled with DVDs and books on breastfeeding, healthy eating, cancer, diabetes, to name a few. Over the next 3 years, we hope to work with all of you on the strategies that you select so that we can collectively impact our community, share best practices of what worked and what didn't work. You shared with the consultants that members and entities must work together as needs change rapidly. You shared that patients need to have advocates brought to them in their community, and you shared teaming up with other large organizations to help fund projects. We heard your recommendations and we plan to act. So our next steps, we're going to help publicize and share the community health assessment and improvement plan. We'll have it on our website and the hospital websites and the health department websites. The hospitals and health departments will implement the relevant strategies that they are working on to align with these CHIP goals and objectives. I plan on helping to reorganize the GMPHP committees to reflect the 4 priority areas of COVID, maternal child health, behavioral health and ACEs, and life expectancy. I'll be sharing the CHIP with you very soon and following up with your organization to see which strategies you are already working on that will improve the outcomes in one or several of these priority areas. We will start to meet again quarterly in the new year via Zoom for now, and hopefully back in person someday. I'm looking forward to reconnecting with you all and rekindling the comradeship and excitement of moving the needle together that we all shared in the last CHIP. I want to take this moment to thank 35th Street, Danielle Waters, Colleen Milligan, and Grace Gorenflo, who have been a joy to work with the last 12 months. I also want to thank our board, which is made up of 26 volunteers who've continued to meet monthly no matter how stressful COVID made their lives. I'd also like to thank the Robert Wood Johnson Fitness Center, Diane Grillo, and Lauren Stebinski for providing the technology and location to kick off the 2021 Community Health Assessment Improvement Plan. Please reach out to me with ideas or new partners. I look forward to working with you in 2022. Do you want to say a few more things? Okay.
Well, we just wanted to say thank you. Thank you to all of you, but especially Carol, for the opportunity to be part of this really exciting process and to get to know so much more about the really engaging and exciting work that you have been undertaking, particularly during this especially difficult time of COVID. It's been a very exciting and inspiring opportunity to watch all of you pivot as the situation has changed, as the virus has come in different waves, and we've had access to vaccines and things like that too. It's been a very inspiring process, and I can't even tell you how excited Colleen and I are to meet all of you that are in this room in real life, because this is our first time. So thank you very much. I'm so excited about what's to come. This is a very exciting opportunity. So we would like to open it up to any questions anyone may have about anything. And please send us your questions in the chat if you have joined us online, and we would be happy to take those questions in that way. And if you're here in real life, you can raise your hand. Yeah, well, thank you then. And we have here, you have Carol's contact information there, and oops, sorry. And here is contact information for me and Colleen and Grace. So if you have particular questions, please feel free to reach out. We're happy to answer any of your questions or to talk about any of these topics. And these slides will be made available through GMPHP as well. And this presentation has also been recorded as well if you want to revisit it in future or share it with someone else. So thank you again for the opportunity to be part of this exciting initiative, and I can't wait to see what comes next.
That being said, anything else for discussion about and have any further conversations we got about.
I was just curious.